Thank you, Jenny. So before we go in the other two sessions focusing on both the internationalization and the policy working group of ICPerMed, we'll start by a celebration of the achievement, okay, that was weird, the achievement of the past 10 years of the European Council conclusion on personalized medicine, as well as the publication of the first strategic research and innovation agenda that I've mentioned. So to begin, we will go to the break before going to the question sessions, and we will hear from Anna Molzen, former chair of ICPerMed, as well as Wolfgang Baden-Stephen, leading a lot of the personalized medicine and ICPerMed right now, of course. But before that, it is my great pleasure of introducing Irene Norsted. She's called active senior according to the commission, but to me, she has always been active. So I would keep it as that. And it's been a privilege, truly, Irene, to getting to know you and working with you over all these years. Of course, active on all our personalized medicine, rare disease activities, but also on bilateral agreements or programs between Canada and the European Commission, which was a first for at least the Canadian Institute of Health Research. So clearly that set some landmarks for us in Canada. And without further notice, I will invite you to the stage.
Thank you so much, Étienne, for those nice words. And thank you to all of you for this very nice welcome to Prague and for organizing this conference. It feels a bit like a family reunion because many of us have worked together for so many years. And the title is, of course, a decade, but in reality, we actually started already in 2010. And the 10-year anniversary is really ICPerMed starting point. But there was a lead period up to that point that was very intensive and that many of you who are here today also participated in. And we started off already in 2010 with a number of workshops to really reflect on what is the state of play and what do we actually need to do. And it was fascinating, those workshops. I remember the one specifically on biomarkers, where we spent the whole day just discussion about definitions of biomarkers. What are biomarkers and how can they be used? And I think we have moved forward tremendously since then. Those workshops led up to our very first European conference on personalized medicine in 2011. It was a very well-attended event and very, very interesting and enlightening discussions that took us further into thinking of how we need to progress this area, because what we need to have is a systemic change. It's very much science-driven, but actually we have a supertanker called healthcare that needs to be changed to really implement the personalized medicine. And we cannot just work on the science, or we need to work on science, but in all the areas from the basic science up to how we implement healthcare and how we look at health outcomes. So we also started to develop first a staff working document on the omics, the use of omic technologies for personalized medicine. And while we started to work on this, there started to be much more recognition for what personalized medicine is, both in terms of the political push, and you have heard about the council conclusions that came in 2015, and that was thanks to the Luxembourgish presidency who really drove this through, and we are ever so grateful for them to do this. Of course, the funding, where we have invested heavily through our framework programs from FP7 through Horizon 2020 and Horizon Europe we are in now, and also through our many partnerships that I will come through some of them today, and also through different programs of the Commission. So not only the research programs, we also have the public health program, the EU for Health, and the Digital Europe program, who are also supporting this development. Cooperation. We have talked about the importance of cooperation. We have several different types of cooperations and partnerships that are supporting personalized medicine. We have, of course, ICPerMed. We also have the rare diseases. We have the 1 million genomes. There are many different types of cooperations that are going in this direction. And of course, legislations. There are many legislations that are also pointing the directions and that should facilitate the implementation of personalized healthcare, such as the European Health Data Space, the AI Act, the Data Governance Act, etc., and cybersecurity, and of course the pharma package, HTA, etc. So it's a lot of different activities that are going on in parallel. I've already mentioned the adoption of the definition of personalized medicine that we're using in Europe. It's been quite challenging to get this kind of accepted and being used, but we try to lean on it, whatever we do, because it gives us an anchor in what we actually mean when we talk about personalized medicine. There's different vocabulary used. We use precision medicine, precision healthcare, innovative medicines. There's a lot of different, but we try to anchor ourselves in the definition. The work we did led up to the next conference at European level in 2016. And that conference was a really fascinating journey because during this period, we started to work closer between us member states and the Commission. And this conference was co-organized with the member states. And we set up working groups. We had 5 different tracks in this conference. And there were different countries taking the lead to organize the program for each one of these sessions. And I think that has really been the key to success for ICPerMed, because it facilitated the collaboration modus operandi and to bring together and also to create the ownership of everybody who has been investing in this journey. And it was also at this conference ICPerMed was launched. I don't need to present it more because it will be presented and has been presented quite significantly, but we are very, very proud of all this achievement and how far we have come in these 10 years since this consortium was launched. Of course, it has been supported by partnerships. We had first the ICPerMed, and I think these figures are probably understated, and I think Wolfgang will give much more precise figures maybe later. But I know that the ICPerMed generated more than 140 million euros investment, which is fantastic. And then if we look at the successor, the ICPerMed, which has maybe twice as many partners, and also will have more than twice the budget. And I think it says more than 300 million, but I think it's closer than 400 million euros already committed. And I think it may go even further with more partners joining, etc., and countries investing in personalized medicine. So it's really, really a fantastic evolution that we have seen over these 10 years that we are very grateful for. It was already mentioned that we have, from the Commission side, also complemented the ICPerMed work with a number of different supporting activities. We have had some which has been very successful that I would like to mention in particular, the EU-Africa PerMed, which has really generated a fantastic platform for our African partners and the participation of South Africa in ICPerMed. We have also the region for PerMed, which has also, I'm looking at Gianna here, which has also been very successful in bringing in regions, because as we know, a lot of the healthcare is implemented at regional level across the world. So it's very, very important. It has also generated more political attention, and we were very grateful for the troika of 3 countries who took up the baton and was driving through their presidencies personalized medicine, starting with the Swedish presidency, the Spanish presidency, and also the Belgian presidency, to continue to address the necessary scientific evolution and also the needs for moving forward. Also, what has happened throughout this journey was, and this came as a surprise, I think, to all of us, and I'm looking at Marius because this was a fantastic evolution, when Romania managed to put in place a national law. And I think Marius will tell you a lot more tomorrow about what happened since this law put in place and what it has generated. And I think it is kind of an inspiration for other countries to reflect on and to see what can happen when you do take a strong political stance. As I mentioned, we are funding personalized medicine not only through ICPerMed, etc., but is through a whole range of different mechanism, etc. From the Commission side, I think we're using all our different type of instruments and also different type of partnerships. So you see here, of course, a lot of familiar logos that we see are very clear contributors to the personalized medicine. So in addition to ICPerMed and ICPerMed, of course, we have the rare diseases and IDERA, because rare diseases is, of course, very much a strong precursor. The cancer mission, of course, another one. And of course, also our partnership with the health industries, now called Innovative Health Initiative, which is also a big part of the work that is invested there, is actually also contributing to personalized medicine. So it's a very sort of big momentum, I would say, with all these different. So even if it's not called personalized medicine, exactly those projects, etc., we know that the basis and the objectives are going in that direction. And we started really from a science push, because we know what science can bring. We know the benefits it can generate. But how on earth do we take it from the strong science base and take it up into healthcare, into applications? And I would just like to take one example that we have worked quite intensively on over this last year, and that is the pharmacogenomics and how to bring it more into the regulatory context. This started from a project that we funded from Horizon 2020 called UPGX, Ubiquitous Pharmacogenomics. And this project was very successful in identifying a number of predictive pharmacogenomic markers that they put into a platform to predict adverse side reactions. And what they demonstrated was that you could achieve 30% fewer side effects when the dosage was tailored to those predictive markers. And they developed a system first with this card that you could bring with you when you travel, and if you need to go to the doctor when you are traveling, you can show the barcode, and then they would know that you have a susceptibility for this particular drug or this compound. It was also supposed to go into the electronic health records. This consortium made a publication in the Lancet, and we were reflecting very much, how can we take this further? Because this is really interesting, and how come this is not better used into really in practice? So what we did is that we started to discuss with our colleagues in the European Medicines Agency about this project, sharing the publication, and reflecting on how can we further build on this. In parallel, there was a second project, a successor funded, called SafePolymed, which is starting to look more at the polypharmacy aspects of pharmacogenomics. And what we did, together with our colleagues in the European Medicines Agency and with the heads of medicines agencies in Europe, you know, every country has a medicines agency, we co-organized a multi-stakeholder workshop. First of all, to look at where is the status today and how does it work in practice? What is implemented in regulatory science, but also how is it used in clinics? It was a very revealing meeting, and there was a very good report, which is now published at the EMA website. And I'm happy to say that only last Friday, we managed to get the summary of this workshop published in Nature Review. And I have put the link there, and we can also send you the link to this article. And I know that Jasmine is here, and I think there may be other who are co-authors of this article who are in the room. Jasmine is over there. And we are very happy. And it was a very timely publication for this meeting that we managed to get it published last Friday. So we hope that this is something that now will be followed up, both from the regulatory side, but also in the reflection into the clinical implementation. We've already talked about cancer, and we know also that cancer is a very strong driver for personalized medicine. It's not always called personalized medicine, but we know that this is the direction where it's going. And here we know that the cancer mission is doing a lot of work. Rare diseases I mean, it's an obvious area also contributing. And here also, I would reflect on the more methodological aspects that rare diseases can support towards personalized medicine, such as clinical trial methods, where we have projects funded and also have gone into regulatory guidelines. And I would also like to mention one of the projects funded in our partnership with industry called ICPerMed, the patient-centric adaptive platform trials, an integrated research platform. So there's a lot of activities going on also in this area, and that should not be neglected because it's really crucial to bring it forward. Also, another important area, and for those of us who were here yesterday, started to allude to the importance of equalities in clinical trials, and looking at different disparities. So we have ethnic, sexual, gender, etc., age diversity, and also the socioeconomic aspects that also should very much be taken into account. And here again, the partnership with industry has already started to pioneer and to go into this area with this project called READY. Something incredibly important as well is what are the healthcare demands? So we are also, from the Commission side, really looking into do what we call a pre-commercial procurement. And that means that we ask the healthcare providers to tell us, what do you need? And then they set the conditions and ask for a procurement that we support to resolve. And here we have had just one successful example I have here. We have several of them. This is on next generation sequencing in general clinical use for cancer. And this has also a successor, and that has been starting to be taken up into practice. Women's health goes back a little bit to this about equalities. This is an arena that is coming very strong on the political side. I think it's good for you to be aware of that, that from the Commission side, we have heard it like every week over this last year. There is something coming in about the importance to focus much more on women's health. So something for you to bear in mind as well. And of course, personalized prevention. How do we do to keep people healthy? What can we predict? What can we do? So here also we are supporting the PROPHET project, and I know that many of you are part of this project to develop a roadmap for more personalized prevention. And with that, I will stop my journey here. We have so much we can talk about, but there are other speakers who want to come in here, but I wanted to give you a little bit of an odyssey of what we have done over this, not the decade, but actually the last 15 years, and it's quite substantial. So thank you very much.
It's such a pleasure to be back. It's been quite a while now, a year now, since I left kind of the scene, so to speak. And it's been so good to see that things are really taking off. So really a pleasure. And another pleasure is kind of also to take the task and look 10 years back within ICPerMed and what we have been doing there. And I would like to touch a little bit more on some of the things that Irene already touched on. And let's see if we can find this one. So the ICPerMed family was actually made possible through very generous fundings from the European Commission. And we have heard the basis for that just from Irene. And you might ask, why was it necessary to have all these different activities? And an overall task of the ICPerMed family has always been to communicate, to promote the concept of personalized medicine, because it was necessary. And you might say we had some regional outreach projects, the Regions for PerMed and SRIA, and they were kind of promoting the concept in Europe. And was it really necessary? It's true that Irene said it's because a lot of it is implemented on a regional basis. But there was also another dire need, and that is 10 years ago when we started all this, it was really not really promoted in some regions in Europe. It was actually focused on some very bigger countries in the middle of what you might call the Western Europe, but there was a need to really go out much broader for people to understand what is personalized medicine about. There was also a need for international outreach, and we had some projects there. We had the ULAC project, which was kind of working within Caribbean and Latin America, and there was really a need there for them to understand and how to develop this. And the basis that ULAC made in these countries is still being felt today and is being worked on still. We also had a couple of projects with outreach to China, a very interesting experience because it was kind of in the middle of the COVID crisis. So travel to China was banned, and we had really a tough time to get this project off the ground. But we managed in really getting some good connections out there and learning what's going on out there. So also there was a need. And latest, we have the Africa project, which has turned out to be very effective and very successful in terms of mobilizing African countries. So from that area, I think it was really some necessary and some good achievements that has been made there. On the more technical side, we also had some projects, and they were actually meant to try to adapt key areas to fit into the PM framework. One of them was the PerMed, where they tried to adapt how to do clinical trials in a PM context, because things had to change. You could not use the usual concepts of how to do clinical trials. Another important one was the PerMed, which tried to understand the health economics of personalized medicine. And I'll come back to that in a little while. And then lately we have the PROPHET project, which is trying to put PM into a preventive context, which is also not a clear-cut deal. How do you do this? Just the question, what is preventive personalized medicine? It's still, in my opinion, an object of discussion. And then we have, of course, the funding activities. Irene mentioned that as well. PerMed, the most successful ERA-net ever. And we are still kind of getting, learning from these projects, and we are still getting benefits out of these projects. They are still ongoing and running. And they have really been a very important basis for the promotion of personalized medicine. And then we have ICPerMed itself, which is a policy and networking and communication platform. And it's been really interesting to be part of that. So as I said, I had the honor to be chair of that organization for 4 years as a representative for the Innovation Fund Denmark. And to follow kind of the development there was really interesting. And if you take a little dive into what we actually did within the project, looking at, for example, the working groups we had, we also see the development of personalized medicine as it looks in general today. So we started out by having a main focus on research. And here I'm talking about maybe biological research at early stage, to go into later in the value chain, to go into clinical studies, to go into healthcare and patients empowerment and so on. And as Étienne said, with the start of ICPerMed, we have now divided it in such a way that ICPerMed is mainly focusing on internationalization and policy and strategy activities. And I think that's a very good division here. A very important outcome of all these ICPerMed family activities was the start of the ICPerMed. So we spent, I think, 2 and 2.5 years doing hours and hours of discussion, how to formulate, how to form ICPerMed. And finally, we succeeded. So it started in November 23. And it's really good to see that it is now taking off. So for me, it's personally a pleasure to see all the difficult things we discussed, all the things about innovation projects, about education projects, and so on. And I think there was some that we had our doubts at that time. Will it ever work? Will it ever be implemented? And now we can see, I can see it's moving on. So call after call is coming out of these different sorts. So I'm pretty certain that ICPerMed will continue to be very successful and very important for the whole field. So all these activities within the ICPerMed family, within the other things that kind of also the Commission did, has it then been successful from a broader perspective, from a societal perspective? And the answer here is fortunately yes. I found one of my very old slides, and it turned out actually that it was still very relevant, because it kind of shows that if you go back, and I would like to use a 15-year span again, and not only the 10-year span, that when PM started out, it was actually starting out as kind of as a scientific specialty. And now, 15 years later, we are starting to see PM concepts being implemented in healthcare systems, both at regional level and also at national level. And I think that's really a major accomplishment, and the accomplishment that we needed to have in order to say that we are successful. I think there's another one, which I also think is a major achievement, and that is that personalized medicine is now considered a key basis for healthcare systems. And this is a realization that has not only come from the scientists involved in there, but it has also been realized by decision makers, by politicians, by payers. And that is, in my opinion, a major accomplishment, because it is kind of the whole basis that we can continue along the path and further develop personalized medicine. So can we then say, okay, is our work done now? Unfortunately not. And here I would like to go back to what we defined as the system of health when we made the strategic research agenda for personalized medicine some years ago. And I do not intend to go into detail here, because then I would need another couple of hours to explain what that all entails. But it's just a figure that kind of shows the complexity of personalized medicine. If you want to develop personalized medicine, if you want to implement it into healthcare systems, you need to address all these topics that are listed on this figure. And all of them needs to be addressed. But the key thing here is to prioritize, because which one of these do we need to address right now, today? And that changes over time. And I think it could be very interesting in this audience, for example, to make a survey and say, for each one of you, can you please make your top 3 priorities of the topics on the field here? And to see whether there will be unanimity. It will probably be pretty different. But in any way, we need to address all these things. And it can be different, the priorities, depending on from where you are sitting. But I have my personal priorities, and I would like to comment just a few of them when kind of looking into the future. One thing is about research. Research is still of critical importance for personalized medicine, not only to develop kind of the basis needed in order to come up with new PM-based therapies and ways of treating people, but also as a driver for still promoting the personal research agenda. And here I'm not talking about research, biological research only. I'm talking about research in a very broad sense. It's also clinical research. It's also health economic research. So it's all kind of research here. So we need to keep on promoting this. And it's going well. So it's not an area I'm so worried about, because it's well funded out there right now. But still, we cannot forget, and say now it's all done. Another area which I also think is important to have more focus on is about health economics. Because you see it very often on slides. I think even Irene has also had it on the slide. Personalized medicine will provide a more economic and more effective treatment of people. But will it also reduce cost, which is something that politicians is very much would like to hear? And this is still an open question. Will personalized medicine make it cheaper for healthcare in the future? I'm not so sure, at least not right now. And a lot of politicians are actually saying that personalized medicine approaches are very expensive. So this is something that needs to be discussed in more detail. And we also need to have more data on the table. The PerMed project and also the Health Economic Working Group of ICPerMed did produce some papers which try to highlight some of these things. But I think it's overall, in my personal opinion, I think we need to look at health economics in a different way. Because one thing is, I understand that it's important that you need to see this particular treatment is costing a lot of money. We don't have the money in the budget for that. That's something that we need to address. But sometimes you also need to go a bit higher level. And you need to look at it and say, personalized medicine, in my opinion at least, will over time produce a much more healthy society. And a much more healthy society over time will automatically reduce the need for healthcare. So this kind of broader perspective is something that is really needed in order to elucidate these things going forward. And then a third thing I would like to mention here is what I call the push the development and implementation of PM from secondary, tertiary care to primary care. And right now, most of it is going on with secondary and tertiary care within cancer, within rare diseases, and so on. But PM is much more than that. PM is also helping all kinds of people, also the ones which more kind of you might call common diseases. And it's a great pleasure to see that the new call coming up within ICPerMed is actually focusing on cardiovascular, metabolic, and kidney diseases. And a lot of these diseases are actually being treated from the GP office, not from the specialty departments at the hospitals. So this is why we need to get it out to the GPs. And there we really have some tasks, because the GPs do not always understand when we say personalized medicine, what do we mean by that? He has very often a very different opinion on that. Another issue which is important here is the GP does not always have the necessary infrastructure and data, for example, in order to go the PM way. So we really need to do something here in order to get it out to the GP. In that way, kind of also the society in general and the people in society in general will feel the benefits of PM much more. And then the last thing I will mention here is kind of the support from payers, funders, and politicians, because this is kind of a need. If you want to continue funding research, if you want to continue to develop infrastructures, we need to keep on telling that this is worth it. It's really worthwhile to go forward here. And this is also kind of where the push getting into the primary care will be a good thing, because the best thing to convince politicians is to create a pull from society. If people in society say, yes, we want PM, then I think the politicians will listen. So I think that's kind of I think that's kind of pretty much my key points here. And there's just one more thing I would like to mention also to this audience, and that is ICPerMed and the ICPerMed family has focused very much on kind of from a very public perspective. And there's much more than that going on, and we fortunately have the IMI and IHI initiatives to work with public-private partnerships. However, in my opinion, we need to broaden that out much more, because I don't think that we will succeed eventually in full implementation of PM without having public-private partnerships. And I could wish that some of the public funders, also represented in this audience, would have maybe a more positive approach to cooperating with the private sector. I think that's one thing that you should take home and try to discuss. I know that there are rules and regulations and laws saying you cannot do that, but these things can also be changed if you work hard enough. So that's just one little wish from me. So with this, I will just say thank you for your attention. I'm looking forward to really the coming days here and to hear more about the latest news from ICPerMed and ICPerMed. Thank you very much.
Thank you for the talks we already had. I started from 2012 to follow the journey. And I agree, I think we came a long way. And I also agree, I have to say that with Einar, that personalized medicine, or whatever you call it, as a concept, started off as a scientific kind of buzzword, let's say. And most of the researchers, and that's nothing bad about it, used it to make an impression for funding. But it moved in the last 10, 15 years really towards to healthcare, and hopefully even more and more, and also with the help of ICPerMed for the benefit of the patients. But before going, well, we had now 10, 15 years backwards, and before looking into the future, also connected with ICPerMed, I did try, and I wanted to do this already a long time, to go further back in history. So maybe to also have a perspective of what we are talking about now, and what we achieved, and in what kind of fortunate position we are, although we have lots of threats. So care diagnosis, I have to write it down, because otherwise I talk hours and hours, there's no point. So care diagnosis and treatment of sick or injured people, along with strategies to stay healthy, are likely to be as old as mankind. However, our records of the very early days and most of the native societies are unfortunately very limited. Some of the known approaches have been successful, and certain traditional methods like yoga, Ayurveda, massage techniques, and acupuncture are still applied. And I show you the first slide. This is a very personal selection. And I can just recommend to have a look at maybe there's others as well, but there's a timeline of medicine and medical technology in Wikipedia. It's extremely interesting. So I did put a couple of these. I do not go across all of them, but I think it's important that already 400 before Christ, Hippocrates started with the rational medicine. And then in the early centuries after Christ, Galen, and I think most of you who are really directly involved in medical care or medical research will know him. He started with medicine based on observation and experiences. And I think part of that is still valid. In the Middle Ages, it was a bit dark when it came to medical care, but anyway. So, and the other thing I think is important, in the past as today, the majority of patients and people are treated individually by a personal contact with one or more healthcare professionals. So, due to the lack of knowledge, technology, and skills, unfortunately, numerous treatments in the past were quite painful. Several worsened the health status, and others were even lethal. Giving blood, I don't know what's the English word for it, but there were a lot of diseases when they said, oh yeah, you have to give blood, and that helps. And in the end, you died, but you didn't die of the disease, but maybe of losing so much blood. Moreover, the many activities were connected to either spiritual, ritual ceremonies, had a religious background or philosophical context, or were connected to, and that's maybe the less good thing, occultism and superstition. I mean, because the people didn't know what was happening. So before the 18th century, mankind accomplished regular medical advances at the best around every 50 to 100 years in average. A crucial impulse, also indirect for healthcare, did start around the 15th century by the invention of printing and replicating technologies to preserve and spread information, descriptions and results in documents and books. I think that was extremely crucial. And another similar step was actually the internet, but that's a later stage. In line with this, common language were used, not only Latin, making the information widely available and accessible, in some cases even until today. Fortunately, over the last 200 years, general and biomedical understanding of the human body, diseases, and healthcare was rapidly increased. The generated knowledge, continuous discoveries, new inventions and technologies, skills, and successful scientific efforts made the healthcare more and more effective. The central key to this development was the start of compulsory education as well in the 18th century. It's not that long ago. And another major step was the establishment of national health insurances starting in the late 19th century, for example, in Germany, where Otto von Bismarck was the founder of the Social Security health insurance model in 1883. So again, it's not a long way. So that's again a personal collection, I would say, over a couple of hundred years. I think if you look at the webpage of Wikipedia, you might pick different ones, but that's my pick. Here I like to mention just a few examples of these groundbreaking developments. The concept of hygiene across all areas of life, the availability of clean water, vaccines, antibiotics, anesthesia, options, the heart-lung machine, dialysis machine, defibrillators, pacemakers, various transplantation options, different types of prostheses, and a wide range of imaging technologies combined with advanced biomedical methods. Actually, from the year 1950, I didn't pick that many because it was almost yearly that something happened. Additionally, the awareness and the opportunity for healthy nutrition and a lifestyle did have a significant impact. Likewise, effective preventive strategies had a positive effect. These advancements were predominantly a result of research-based activities and successes, increasing knowledge, and thus were crucial for the development of effective healthcare. And here we come. This is very impressive, I think. All of these positive developments led to a continuous and substantial increase of global overall life expectancy at birth over the last 150 years. And this is in fact independent or not that much affected by a lot of things which were opposing, like wars, some pandemics in the early ages as well. But for example, in 1900, the average worldwide life expectancy was 32 years. And 50 years later, in 1950, the average life expectancy was 46. And in 2020, just to make this 50-year step, it was 72 years. And at the moment, at least in let's say in the European countries, I would say that for women, you go definitely over 80. And for men, you go close to 80. So it's really amazing. The extraordinary rise of this is the result of a wide range of advances, including public health efforts, positive effects by the overall improvement of living standards, economic growth, and poverty reduction. I think you should not underestimate that. And one of the strongest parameters also, especially in the beginning from the, let's say, 1900 on, or maybe a bit earlier, is actually the possibilities that you have much less infant death. I mean, a lot of people had a lot of children because they had to expect that some of them die already in the first 1-2 years. So that's also something very important. It's actually remarkable that this progression remains constant despite several conflicting factors, such as regular pandemics worldwide, national and regional conflicts, negative effects caused by industrialization of our modern lifestyle, or geopolitical and environmental developments, including different kinds of pollution, an immense global increase of types of waste, and the continuous climate change. I mean, there's a huge area who just cross-check the between environment and health, which is important. Today, though, we might have the impression that medical innovation is pretty slow. But compared to the historic view, it actually gained speed, particularly over the last 100 years. Besides, there are far more specific approaches, solutions, and drugs available, which are also more precise and have reduced side effects and risks. The mentioned impression might be caused by an ending area of low-hanging fruit successes, like effective antibiotics or vaccination. Additionally, existing and new diseases are getting more and more complex and challenging, partly due to our improved knowledge and very effective healthcare, but also as a consequence of a higher life expectancy and some aspects of the demographic change, leading, for example, into an increase of chronic disease and multimorbidity. Fortunately, early in the 21st century, further impressive biomedical, methodological, and technological achievements occurred. These were actually the origin and the basis for defining the concept of stratified, precision, or personalized medicine. And I remember 4P as well, and a couple of others. But in fact, as I said already a couple of times, it doesn't matter how you call it. It's modern medicine using all the biomedical knowledge you have and all the available technologies to give the best diagnosis, treatment, and prevention. Very simple. With enhanced technologies supporting genomic and proteomic analysis, biomarker identification, we extended our biomedical and multiomics knowledge. Moreover, we have now a wide range of imaging tools available with a huge impact on optimizing diagnosis. In parallel, we gained the possibility to generate and analyze complex multivariable data sets, for example, obtained from electronic health records, clinical or lifestyle settings, more rapid and efficiently. Although we might not do this in a common way across Europe, but that's challenging. And we are already happy if we do that on a regional or national level. Moreover, other technologies like the comprehensive use of smartphones, the option of health status, and treatment-related apps and wearables have a huge potential and might support monitoring activities. I think that's another crucial step for the future, especially if we have smaller and smaller cohorts for the clinical trials, that we have a really good kind of technological setting in our hands, that we do the monitoring while the people take the drugs, while the people have the treatment. Nonetheless, we have to be prepared for novel or reactivated health challenges in the present and in the future. Here, I like to mention just a few and the corresponding co-funded European partnerships. Moreover, these partnerships are supported by numerous other measures and actions in Europe and beyond, and also on the national level, which is crucial. So pandemic preparedness, that's a European partnership just started, and it's called Be Ready. Antimicrobial resistance, there's a partnership also just started called One Health IMR. Cardiovascular and metabolic diseases, as well as transnational clinical research, that's ERA for Health and others. Neurodegenerative diseases and mental health, that's Brain Health, will start soon. Then we have cancer, where we have the already Irie mentioned that the cancer mission, and they are still running an ERANET co-fund called TransCan, and I think they are quite successful as well. And also mentioned before, a large number, and I did put that on purpose, a large number of rare diseases. So, and that's IDERA. And then on the other hand, we need to have improved and effective national and regional healthcare systems. And there's the partnership called Transforming Healthcare Systems, THCS. So that they're all in place. And I think there's a good reason that they are in place, because you cannot develop and establish a co-funded partnership if you do not have at least 2/3 of the member states on board. Otherwise, it's not working. And the Commission supporting a lot of these activities. So, and finally, for personalized medicine, that's ICPerMed, which contributes to most of the before mentioned challenges. Also, that was mentioned before. So if you go, let's say, I will talk about that later, we will have a call on cardiovascular, metabolic diseases and kidney. So yeah, there will be personalized approaches in these fields, because sometimes we have to go away from rare diseases and cancer, because they are already so developed, let's say it this way. Nevertheless, we also have tools to support this area. Besides the research achievements provided and required, you all know that diagnosis, treatment, or prevention strategies need to overcome additional hurdles and bottlenecks before people can benefit and profit. I mean, that's maybe not people, well, they profit as well, but the profit is mainly for the private sector. But it's important. I mean, it's important that they do profit, that they have a system where they get profit. And then in the end, we will have also a benefit, and that's maybe sometimes underestimated when it comes to employment. So a lot of jobs, because of AI and other developments, might reduce, and then new jobs have to be generated. And I see definitely personalized medicine and other topics in the healthcare system which should develop new jobs. But that's maybe a big piece of wood to drill. But I mean, there's a perspective. Okay, so the bottlenecks are the essential, and I put on purpose the essential regulatory approval. So we do not want to have any type of drug or treatment which we cannot trust. That's really important. I know I hear that very often. The regulation system is so complex and we need to make it easier. No, we need to make it efficient. Let's say it this way. Then health technology assessment is more or less the same, as well as clinical validation in a real world setting. Then, Aina, you mentioned that before. I make it short, but I completely agree. Health economic evaluation by defined and available models and data sets on different levels and for multiple purposes. That's another thing I've learned being partner in ICPerMed, that you have different models and different data sets depending on what you are modeling. Do you model for a private partner if it's worthwhile doing research? Do you model whether it makes sense that you go forward into the implementation? And even more important, and a really black box, at least in my opinion, reimbursement and pricing. And these are all models which are used, and they can be different, and they depend also on the data sets which are used. And I think there is definitely a need to adapt to the modern world. So here we need to guarantee that health and care remains affordable, equitable, and social. Thus, the healthcare system should not be reduced, and some might laugh when I say that, to a pure ecosystem. It's not only about money. That's at least my understanding of ecosystem. Okay, so there was mentioned before, there's publications from ICPerMed. They're extremely interesting, from ICPerMed as well, and I'm sure there's more out there when you're interested in this topic. Thus, a more comprehensive approach needs to be developed and established, covering societal perspectives and taking into account latest achievements and innovations. This could as well be in addition to the existing models and approaches, but they have to be adapted. I'm not sure who should be the driving force there, because I mentioned before, this is usually a contract which you have. But I think health economic research might be the key to further develop this. So then, at least, if not more important, health insurances considerations, decisions along with their available budget lines, and ensuring sustainable and fair healthcare. I mean, there's no point in having extremely, like Aina said as well, extremely expensive personalized approaches, but then only, I don't know, 2% of the population will get them. And there's another perspective, and that's not related to the healthcare insurances, but it might depend where you live, in which country, in which region, if in the countryside or in a city where you have a university hospital. I mean, we should make sure as much as possible, and that's a policy level as well, that we have kind of a fair access to this. Then healthcare professionals and other providers who are capable, willing, and adequately reimbursed to support innovative approaches like PM. People and patients who are informed, engaged, committed, and compliant. Compliant is really also a very important thing. And I have to refer to the ICPerMed vision paper. There's a couple of these things in there, and they're still valid. So, and another thing which is extremely important, and we have to take care that is not going to get lost. Trust in and within the healthcare systems, and the belief that they are capable and willing to offer the best possible support, which is sometimes a balance between the pressure from patients and relatives to get a quick and precise diagnosis in combination with a tailored and effective treatment. I mean, they expect this. And I know, again, I don't like to overdo it with my mother, but she's going to the doctor, to any kind of doctor, almost every week. And it's hard for me as a son to tell her, okay, these things cannot be treated in your age with this multimorbidity situation. You have to respect this. But it's difficult. I mean, I don't say it's easy. So, and then on the other side, the risk of severe side effects and mistakes which might lead to lawsuits for compensation, and the existing and accessibility of enabling frameworks which need well-educated and dedicated professionals, enough capacities and resources. It's very simple, but it's challenging. So additionally, we have to react, and I think that's also important, I mentioned that already before, to react on the increasing skepticism towards medical treatments such as vaccinations and other innovative medical approaches. It didn't start with Corona, but it got a huge push with Corona. I know in Germany there's these people having these alu hats, and I don't know why, but we should not lose them. We should communicate with them. And also we need to communicate to the people that innovative approaches can help them. The earlier, the better. So therefore we need, and that's the next point, therefore we need to faithfully communicate with the public as well as with other required stakeholders to inform and engage with them. And we have to be open on all levels, that if something is not working or something is really too expensive or any other problems, also there we need to be transparent. I mean, we should not I know from gene therapy, that is really a long time ago. When that came up, everybody said, no, we're going to treat every disease. No, we cannot. We can treat very precise and specific monogenetic diseases, and then we need a precise vector to get to this place, or that we get within the body into this place, have the exchange with no side effects. This is not simple. But when they started with gene therapy, also the press, they kind of overdone the possibilities. Now we're getting closer that we have really these approaches working, but that takes time. Coming back to the historic view, this seems to be a long time, but it's not a long time compared to the hundreds before. So in this slide, you have already, in this slide, have you already asked yourself if you and/or your family had benefited or contact with personalized medicine in diagnosis, treatment, or even for preventive strategy? I would suggest that 50% of the people sitting here can say yes to this answer. And I think, and I hope it will be even more in the next meeting we will have. So actually, I myself have, for my own and my twin brother's diagnosis of polyneuropathy, potentially caused by a genetic variant, tests. So after several other tests, we did have an exome analysis which consisted of two steps. First, the selection of a subset of DNA that encodes proteins. The second step was to sequence the encoding DNA, our DNA, using a high throughput DNA sequencing technology. Actually, nobody asked me if they can use the data for research purposes, just as we discussed it yesterday. Unfortunately, we did neither get a more specific diagnosis nor there is a treatment option available. Maybe in the future will bring more knowledge and options for us. In any way, I'm convinced that only research efforts can gain promising opportunities for more precise diagnosis and the hope of an effective and safe treatment. I actually was a bit disappointed because I thought, oh, I'm a researcher for medication, so I thought, oh, they see it's a gene variant which they don't have yet identified, so there must be a researcher being interested. No. So that's maybe also the tricky bit when it comes to rare diseases. I wouldn't call that a rare disease, but the point is who is paying for this research and how long does it take and who will benefit. And here again, like I said with my mother, I have to accept this. Not everybody can be cured. We do whatever is possible, but there might be a limitation there. Okay. So that was the part which I usually do not do. So finally, I like to shortly present some settings and goals of ICPerMed and highlight examples of innovative calls and activities which aim to support not only excellent PM-related transnational research, but also the development of related innovations and their successful implementation into as many healthcare systems as possible. So just some of you might be bored because you saw that so often, but some of you might not know, so I have to do it. Yeah, we started actually in ICPerMed with 54 partners. Now we have 61. I would say we have almost covered all member states, maybe 2 missing. I'm not exactly sure, but that's also dependent on small countries. They have to decide where they put their money. And we have 28 countries, and I'm very happy that we have 11 regions on board, quite a few from Spain, Italy, 1 from Germany, and Portugal we had as well. I hope I didn't forget anyone. But they are also, what was said before, crucial that we get really the things into the healthcare system. And even if we only go for pilots, which then can be used by other healthcare system owners, if you can call it like that, or hospitals, to put them into their system as well. So the total budget at the moment, and I refer to Irene, is 375 million. So the 100 million, 100.5 million actually from the EU budget, but there might be an increase on the national, regional funding from the partners. And I would and the lifetime will be 10 years. And we will see how the future will be. And I have to say thank you for the Commission, I mean, for the whole journey, for supporting us here, also especially the unit responsible for personalized medicine. I have to say, and this is not fishing for compliments, I really enjoy the work with them. They are very constructive, they are open, they're transparent, perfect. So yeah, we hope we can together continue, and then we will see how things develop. Okay. Then this is, and this time I read it actually. This is the vision of ICPerMed. It's really short, but it's really with lots of impact in there. So the vision of ICPerMed is to improve health outcomes within sustainable healthcare systems through research, development, innovation, and implementation of personalized medicine approaches for the benefit of patients, citizens, and society. And the reason why I marked the different words, research, innovation, implementation in the, I hate this. The reason is, and I will do that shortly, that we have the logo and which is actually put together in a Möbius band, for blue for research, yellow for innovation, and green for implementation. That's the color code we use. We have work package 5 as well, which is purple, which is the same important, but doesn't fit that well here. Maybe we should do it around in purple, but then it's getting too colorful. But I think it's a nice, and we did that in a transparent and democratic way, but I think it's really a nice logo. So the core of ICPerMed are the co-funded transnational calls. And we actually have 2 types. We have 7 annual joint transnational calls, and they are listed here. I, again, will not go into depth here, but I think it's important that you all know that the 3rd call, which is called JTC 2026, Personalized Medicine for Cardiovascular, Metabolic, and Kidney Diseases, is just opened yesterday, I think. So So that's good. And again, I don't know, he doesn't like me. The other co-funded call is the Research Innovation Technology call, which opened already a couple of weeks ago, I think, or yeah. And that is a very important call because that's actually aiming as a co-funded call. Co-funded means budget from the interested and dedicated members of ICPerMed. I would say 85–90% are actually funders and health ministries. So they give budget, and that is kind of topped by EC budget from ICPerMed. I don't know. Okay, there's again. Sorry. And the topic of the first call, and have a look at the website, is test and demonstration of multimodal model data approaches for PM. And I did hear from the people responsible that it seems to be very, very well taken. So we'll see. And then that's the co-funded calls. And on the other side, we have I call them ICPerMed calls. Actually, what we are doing when we're going into the innovation system and into the implementation system, what we do is we have now calls developed specifically for some of these steps, and we use EC share from ICPerMed to do the funding. This is not a huge funding. The idea is to give an impulse to really to move forward in the innovation setting and also in the implementation setting. I will go maybe in more detail. I have to check. I did write something, so I make it not too complex. That's another thing. So at the moment, we have dedicated 100 million for the 5 calls we have. So we have 2 JTCs, 3 JTCs. One is open, and 1 research and innovation call, which is open. Within these 4 calls, we dedicated 100 million from the partners and the national and regional funders. And we do not exactly know, but approximately 17 million from the EC share as a top up. Which is important there as well. So, and something which is also important that within these co-funded calls, starting from the JTC 2025, continuing with 26 and with the research and innovation call, we foresee the possibility that the building and submitting proposal consortia can take on board a patient organization. And learning from ICPerMed, we said, okay, some of the funders can actually fund patient organizations, but some cannot or do not want for different reasons. So we said, okay, they are so important that we reserve a certain budget from the EC grant we have, that we fund them. And that was extremely successful. So yesterday it was finalized. There will be soon information on the website and further information. In the second call dedicated on pharmacogenomic strategies for PM approaches, we have 22 consortia funded and 14 have a patient organization. That's, I think, impressive. And we hope the same is going to happen for the next 2 calls, co-funded calls. So yeah, we're going forward to this. Okay. So coming back to the ICPerMed calls, it's good, I did write that down. Luckily, we do benefit from the existing healthcare and research advances, for example, of the 111 ICPerMed transnational consortia, which are already very active. Some of them already stopped because they started in 2017, yes. So they always have a time span of approximately 3 years. And there's a couple of hundred, I think, I don't know if I say something wrong, but these consortia have already 600 publications. So that's, as I said, research is maybe not the biggest bottleneck at the moment. So that's impressive. We start to see promising results also beside the publications and some of the results finally reaching the patients. ICPerMed is supporting this effort wherever possible. And some of the calls on the right side of the slide are actually dedicated to also the ICPerMed consortia or partly researchers that they can try to go for the fast track and the twinning call, the network support call, and also the others. In this line, I would like to, again, I'm not explaining the whole ICPerMed, it's just too much. You're welcome to contact me or somebody else in the coffee breaks and the lunch breaks who are involved in ICPerMed. But I like to highlight two ICPerMed calls aiming at this task. That's the fast track program which is addressing a critical bottleneck in the development of PM solutions, the validation phase, to ensure they meet the needs and expectations of end users, including clinicians and patients. So in the first fast track, we now fund actually 3 projects more than we originally planned. So there's 8 projects funded, and the second call is just announced. So, which is important, we have a database on the webpage, ICPerMed webpage. You find all the consortia from ERA-PerMed in there. You find now also the 8 projects from the fast track call in there, and you find the 27 projects consortia from the first ICPerMed call in there. And there will be the JTC 25 consortia as quick as possible included there as well. So that will always be an interesting source of information. Okay, information, that's it. Then another innovative call facilitates the national implementation of PM approaches and solutions to another transnational location, a so-called twinning process for PM approaches. The aim is to connect PM donors. I have to stop? Okay. PM donors with transnational PM receivers interested to a peer-to-peer exchange. Thus, we're encouraged to spread successful PM solutions across Europe. And maybe we're thinking of having something like a brochure about the donor projects, because they are also best practice examples. The deadline is February 26. So then I come to the end. So, beside the calls, which are the core elements, we have other activities. This conference, we had a conference in 2024 in Berlin, very much dedicated to PM research. We have a venture creator mentoring program. The first one is now finishing beginning of December, and lots of other things. So I think it's important that you know that we have these podcast series. We have one from last year. Very interesting. Have a look. You can go either via the ICPerMed webpage, or you go via Amazon, Spotify, and also the Apple things. So they are also presented there. And we will have the live recording of at 9 o'clock in this room. If you're interested and silent, you can watch that. I think it's extremely important and interesting. And last but not, that just moved already again. Sorry, I'm almost finished. So last but not least, I have to mention that we have 3 advisory boards, and we had a meeting yesterday morning with them, and I really appreciate a lot their dedication and their interest, and I'm really looking forward to all the input they already gave and they will give. So that's interesting. And then the very last thing is, we should always remember, even if we succeed in improving healthcare and prevention with the help of personalized medicine and alternative parallel efforts, we remain social beings. And we need a social setting to remain or get healthy. In this line, we all know and already experience that we need people, family, and friends, as well as all healthcare professionals, to individually support, cure, and take care of us, especially in times where we ill or suffer. Therefore, the main source of support will be our real-world social network, supported by healthcare professionals with their dedication, knowledge, and experience, and their daily work. So, thank you.